So if you're joined, please write your name so that I can identify uh, the person that have joined. Please write your name. I can see two people have joined already. So write your name, please. Okay, okay. Okay. It's Gani that is Saibi. I was wondering who is Saibi. Okay, you're welcome. Who else is here? Please, okay, we have some people already. Please write your name. Let me know who is here so that we start. Please, please write your name. Okay, Aishat is here. Okay, who else is here? Okay, Anas has joined. Okay. All right. So good evening, everybody. We'll continue from where we stopped. We stopped at I was discussing calcium, and I said I wanted to give you guys some scenarios to see how you can answer. How you can answer. Sorry, my voice may not be very clear. I have cold. So we'll continue. So please have a pen and paper. Let me give you a scenario. Let me see if you can make diagnosis. So if you are ready for today's discussion, please write ready, sir, ready, sir, ready, sir. So that we'll just conclude calcium and conclude endocrine. So that we'll start gastro that gave you guys some headache. Okay, so if you are ready, write ready, sir, ready, sir, ready, sir. Okay, Aisha is ready. Who else? Good. So I said if an individual has low calcium, normal phosphate, high parathyroid hormone, and low vitamin D, what is your diagnosis? Low calcium, normal phosphate, high parathyroid, low vitamin D, what is your diagnosis? Because like what I gave you in the picture test in your mock exam, what I wanted to see is severe hypocalcemia secondary to so. Right? Some will say hypocalcemia, they will not say severe. Some will say give diagnosis. I told you yesterday it's very important for you to know the normal range. Any calcium that is less than 1 is severe hypocalcemia. Let me just say it. Okay. Okay, so likely vitamin D deficiency. Good. So likely vitamin D deficiency because the parathyroid is hormone trying to compensate for the vitamin D deficiency. All right. Okay. All right. Okay. So the next one, if calcium is low, phosphate is high, parathyroid is high, vitamin D is low, what is your diagnosis? Calcium low, phosphate high, parathyroid high, vitamin D low, what is your diagnosis? So let's get those things straightened up. So what is your diagnosis? Kindly type. All right, I'm waiting. Aishat, I'm waiting. Gani, I'm waiting. What is your diagnosis? Okay, very good, Sumaya. Vitamin D deficiency from CKD, right? Because the phosphate is high. Good. So it's like if people understood endocrine very well. And if it is so, the fact that you understood, let's just go straight to the point. And if it is hypoparathyroidism, the vitamin D and the parathyroid will be low, isn't it? So, does anybody have any question on any aspect of endocrine? I'm going to close the chapter of endocrine now so that we'll go to gastro. If you have any question on endocrine, you have 1 minute to ask. So the gastro, I'm going to go through hypothetical questions. And if you have been taught that topic in class, you say you have been taught. So if there is no question on endo, please write proceed so that I'll proceed. If no endocrine question, write proceed so that I can proceed. So the phosphate that is high in CKD is because a particular factor called fibroblast growth factor 23 is defective. And this fibroblast growth factor 23 is responsible for the excretion of uh, responsible for the excretion of phosphate. So that's the main reason, right? Because it's expected that if parathyroid is high, which normally excretes phosphate and absorbs calcium, the phosphate shouldn't be high. But the reason why the phosphate is high is because of the CKD itself. You understand, Adetola? Because you sound like a paradox, isn't it? The parathyroid the parathyroid hormone is high. Why is phosphate still high? It's because of the kidney disease. There's defect in the function of the FGF23. Hope you get it. Aditola, okay, very good. Since you got it, it's all right. Okay. So please, if you're okay with endocrine, please write proceed. Okay, Aisha wrote proceed. Who else? I want to see 3 or 4 proceed so that I can go ahead. I can see it's only 10 people. 2 people are not here. Who are the 2 people that are not here? This discussion is very important. Okay, I've seen to proceed. I need, okay, I'd like to proceed. Please, the 2 people that are not here, I don't know what is the excuse. So let's begin gastro. Have you been taught primary biliary cirrhosis? Have you been taught primary biliary cirrhosis or cholangitis? Yes or no? If yes, please write yes so that we discuss the question. Have you been taught primary biliary cholangitis? If yes, please write yes. Yes or no? Have you been taught primary biliary cholangitis? Please respond. Then I can ask you certain question. so that we get it right. Okay, Oli cholecystitis. Sumaya said Oli cholecystitis. Do you all agree with her? Okay, no sir, no sir, no sir. Okay, so let's move to another thing. If you have been taught, okay, okay, no sir, no sir. How about Barrett esophagus? Barrett esophagus. I want to make sure there is no loose end in this gastro. How about Barrett esophagus? Yes or no? Want to cover, we'll have time to cover cholecystitis and the hepatitis that you people talk about, but I want to use the opportunity to cover everything that you have been taught so that we see the salient points in each of the gastro topics. So how about Barrett esophagus? That abnormality you see on the lower esophageal mucosa. Yes or no? Suraya, have you been taught? Uh, I'm waiting to see your typing. You have not been taught that one. So what are the things that you people were taught now? Okay, how about varices, esophageal varices? Let's say variceal bleeding. Have you been taught variceal bleeding? Have you been taught variceal bleeding? Okay, only of okay, esophagitis. That Barrett's esophagus is part of it, but no problem. Okay, how about variceal bleeding? Because me, I asked a lot of people about variceal bleeding during the orals, expecting that they have taught you. I hope I was not wrong by asking some people that question. Have you been taught esophageal varices or variceal bleeding generally? Variceal bleeding, have you been taught? You people have not covered a lot of this. Upper GI bleeding is part of variceal bleeding now. See, they will ask you, so listen attentively. Listen attentively. This one, even if you have not been taught, they will ask you. Because personally, I ask a lot of people in auras. Okay? So, let me read a question. You pay attention. If a 31-year-old presented with passage of melena and hematemesis, right? And the BP was 104 over 60, pulse was 110. What is the definitive therapy? I'm not asking for the initial therapy, but the definitive therapy. Is it surgical referral? Is it endoscopic bowel ligation? Is it endoscopic sclerotherapy? Or is it none of the above? So if someone presented with uh, hematemesis and melena, and the person has history, okay, additionally, the person has history of alcoholic liver disease, right? He presented with hematemesis and melena. The pulse was 110, BP 104 over 60. What is the most important, most appropriate treatment? Is it surgical referral? Is it endoscopic bowel ligation? Is it endoscopic sclerotherapy? Does anybody has any idea? Any idea? If no idea, please write nonsense. Then I can discuss variceal bleeding. Okay. Saib said, so if somebody had alcoholic liver disease, the likely thing is varicose bleeding. And if an individual has varicose bleeding, the best treatment for varicose bleeding is band ligation. Band ligation, please. So, how do you manage varicose bleeding? Usually, if you see a scenario about varicose bleeding, right, they would definitely tell you that that individual has some kind of liver disease. And varices are just dilatation of veins, either in the lower esophagus, in the stomach, in the rectum, or any other place where there is anastomosis, systemic anastomosis. So how you manage when somebody comes with varicose bleeding? First is resuscitation, the ABC of resuscitation. When you are doing the circulation, you check the pulse and the BP, calculate the shock index. After you have calculated the shock index, when you're putting your whiteboard cannula, you take sample for PCV grouping and cross-matching clotting profile, right? Before your grouping and cross-matching comes in, you uh, you start normal saline, and when your blood comes in, you give blood. But if it's varicose bleeding, you don't do massive transfusion. You do what we call restrictive transfusion, where you don't give too much blood in a day. If not, the varices will be engorged and the patient will bleed again. Right? So after you have stabilized the patient, before endoscopy, where it is available, you can give telepressin or octreotide. Telepressin or octreotide. The use of these ones is that they cause splenic vasoconstriction, the blood vessels in the those areas. It causes constriction so that there won't be continuous blood supply to the portal system and bleeding. Well, where it's not available, you can go ahead when the patient is stable to do endoscopy. So while doing endoscopy, right, you do band ligation. And another important thing that can help you before the band ligation is you give intravenous erythromycin. Erythromycin is a prokinetic drug. So it helps to clear the GI of the blood that is already in the GI so that you can see clearly and do the band ligation. So, but if it is really secondary to liver disease, the definitive therapy after you stabilize your patient is TIPS, and I know they have taught you TIPS in surgery: transjugular intrahepatic portosystemic shunt. So this is how you manage varicose bleeding. And when the patient is stable, what you need to do is you need to give the patient propranolol. Propranolol reduces the portal pressure so that the pressure in the portal system will not be high and the varices will not develop. And you can also do prophylactic band ligation. Any blood vessel that is engorged, you do ligate like you're tying something so that the blood vessel will deflate. The one that is engorged will deflate back. Okay, so that's how you manage varicose bleeding. In a summary, if you say this thing, there's nobody that will fail you. So the endoscopic sclerotherapy, and I asked someone during the orals also, the endoscopic sclerotherapy and endoscopic injection of adrenaline or no adrenaline are used for patients with bleeding peptic ulcer, not for varicose bleeding. It's for bleeding peptic ulcer disease. So any question concerning what I just said? Does anyone seek any clarification? See, if they don't ask you in MCQ or in clinicals, they'll ask you oral. So you must know upper GI bleeding is not only peptic ulcer. Varicose, for me, even in this environment, we are seeing more varicose bleeding than peptic ulcer bleeding, because before peptic ulcer leads to bleeding, it must have been very severe, right? So we see more of varicose bleeding, people that have chronic liver disease. So any question, or if not, please write proceed. If there is no question, please write proceed. Okay, Sir AB say proceed. Okay, anybody? I need to see at least four people saying proceed. I have to, but remember also said proceed. Okay, so good. So the next question is on peptic ulcer. You were taught peptic ulcer. Even if you are not taught, you must know it. So the question is the following are diseases caused by H. pylori, Helicobacter pylori. So which one is wrong? The following are diseases caused by H. pylori except one, peptic ulcer disease. That's A, let me say. So how do you differentiate varicose bleeding from peptic ulcer disease? If you meet me, I'll ask you this question. How to differentiate varicose bleeding from peptic ulcer disease? I'll ask. So first of all, in the history, somebody with CKD will have history of abdominal swelling, maybe previous history of jaundice, body swelling. Somebody with peptic ulcer will have history of the ulcer, epigastric pain radiating to the back. Then during the bleeding, the peptic ulcer disease is painful hematemesis. That means there must be pain before they vomit the blood. While varicose bleeding is painless hematemesis, right? Then secondly, varicose bleeding is brown. The reason why varicose bleeding is brown or dark is because varicose bleeding is from the vein, while peptic ulcer bleeding is bright red because it's from the artery, right? And varicose bleeding is usually more massive than peptic ulcer bleeding. Suleiman Anas, hope I answered your question. Please indicate if I have answered your question, Anas. We're waiting for Anas, but we will not wait too long. Okay, so aka ce shiru ma ansa ne. So let's continue. I was talking about Helicobacter pylori, and I was asking that the following are diseases caused by H. pylori: A. Peptic ulcer disease, B. Gastric cancer, C. B cells lymphoma, B cell lymphoma, D. Atrophic gastritis, E. Esophageal cancer. So the following are diseases caused by Helicobacter pylori: peptic ulcer disease, A; B. Gastric cancer, C. B cell lymphoma, D. Atrophic gastritis, E. Esophageal cancer. Which one is the except? Which one is the answer? Which one is the answer? Okay, Wilfred says C. That's B cell lymphoma. Okay, Sumaya also says B cell lymphoma. Okay. Adetola, I want to see your answer. Uh, okay, B cell lymphoma. Okay. So actually, the answer is E. Okay, esophageal H. pylori does not cause esophageal cancer. Remember, it's right. So it doesn't cause esophageal cancer, but it can cause B cell lymphoma of malt, which is called maltoma, right? Can also cause peptic ulcer. It can cause gastric CA. especially when metaplasia has undergone and also subsequently cancer can cause atrophic gastritis. So it doesn't cause esophageal cancer. And remember the triple therapy for treating H. pylori infection. Remember, there is proton pump inhibitor, there is an antibiotic which could be amoxicillin or metronidazole, then there is clarithromycin, right? So don't forget that. Have you been taught hemochromatosis? Hemochromatosis. Please write yes or no. Have you been taught hemochromatosis? Okay, it's only hematology. Okay, so let's jump it since you have not been taught in gastro. Okay, let me see any other important. Okay, it's okay. So how about gastroenteritis? Even if they did not teach you, this is important. Were you taught gastroenteritis? Okay, so Sumaya say yes, gastroenteritis, yes. Okay. So I want to teach you some important things about gastroenteritis. If you have your paper and biro, you can jot. Pay attention. Okay. You know, E. coli causes, it has different serotype. You have the enterotoxigenic, which is just acts just like cholera, giving you watery diarrhea. You have the invasive, which is a bit bloody. You have the hemorrhagic, of course, which is bloody. The invasive can be bloody and mucoid. You have the pathogenic, which is mainly mucoid, right? So, but one thing you should know in gastroenteritis is E. coli gastroenteritis is usually associated with people that have traveled, people that have changed. Let's say now you travel to your village, you came back and you're having watery stool. So that is suggestive of E. coli. And you should know that E. coli incubation lasts up to 12 to 48 hours, right? So it depends on the strain of the E. coli. And you know, E. coli can give you hemolytic uremic syndrome, the serotype, I think H0157, right? Then you know cholera also, it just acts like toxin. But one characteristics of cholera is rice color, rice water colored stew. That's why during your exam, so people that got gastroenteritis were saying differential of color. How can you be cholera? You said the stool is watery, normal color, right? And you're saying cholera. It doesn't make sense, right? So it has to be like rice water color. Then there are certain Staphylococcus aureus and Bacillus aureus give you symptoms of watery diarrhea between 1 to 6 hours. But you know that Staphylococcus Bacillus cereus is notorious with rice, right? Somebody that has eaten rice. And those that will give you bloody diarrhea include the Shigella. Campylobacter may or may not give you bloody diarrhea. And Mobiasis will give you mucoid. Someone got a mucoid stool, everything. The history was superb, abdominal pain, even tenesmus, but couldn't make the diagnosis of amoebic dysentery, right? So amoebiasis will give you that mucoid stool, abdominal pain, tenesmus, fever, right? And amoebiasis is very common in this environment. But any diarrhea that is more than 7 days is either the amoebiasis or giardiasis. Giardiasis is commoner in patients that have HIV. So during the clinicals, the person that got the gastroenteritis, the likely diagnosis was amoebic dysentery, but he couldn't get it. But for me, if you make any the diagnosis of gastroenteritis, you must not get the specific diagnosis. I'm not looking for that. I'm just trying to see if you can make diagnosis of gastroenteritis and manage it. But I'm not the only one doing exam, right? So you should know these hours. In the exam, what did they ask you about gastroenteritis so that we can answer it if anybody can remember? If you can remember, please indicate. If you cannot remember, I can give you scenarios now. If you can't remember, just write can't remember. Say that then I can give you my own scenario. Okay, AB said didn't get the cause of mucoid. I say mucoid 2 is usually number one culprit is amoebic dysentery, right? Other ones are E. coli, like the enteropathogenic E. coli, the strain, or enteroinvasive, but invasive can also have blood, right? Then, okay, I've mentioned then Campylobacter, but Campylobacter also is with blood stain. But mostly the one that will give you mainly mucoid is the amoebic dysentery and enteropathogenic strain of E. coli. Hope you got it. But the Campylobacter and enteroinvasive will give you a mixture of both mucoid and bloody. Okay, so AB, hope you got it. AB, right now, if you got it, so that I'll move forward. I don't want anybody to be left behind. Oh. Okay, good. So, how about hepatocellular carcinoma? They even ask you a long essay question on hepatocellular carcinoma. Hope you guys were taught so that we can address some things about hepatocellular carcinoma. Were you taught? Please write so that. Okay, so Maya, right? Yes, sir. We were taught. Good. So listen, what is the most common cause of hepatocellular carcinoma in this environment? Is it hemochromatosis? That's A. Is it hepatitis B? Is it alcohol excess? Is it aflatoxin? Or is it hepatitis C? Which one is a common cause of hepatocellular carcinoma in this environment? Very good. So it's hepatitis B, right? Because hepatitis B is regarded as an oncogenic virus, right? Okay, and you should know that the common symptoms of hepatocellular carcinoma is right hypochondria, uh, pain, and sometimes they may have hepatomegaly, pruritus, and other symptoms, right? And what is the test for diagnosing hepatocellular carcinoma in this environment? What definitive test will you do for hepatocellular carcinoma? Write it, please. If you do not know, I will answer. What is the test that you do to confirm hepatocellular carcinoma? Okay, what is the test? Okay, triphasic CT scan. Very good, very good, very good. So, I know that you can also do alpha fetoprotein and other tests, right? And the treatment of hepatocellular carcinoma depends on the stage. If it's in the early stage, you can do surgical resection. But and also in the early stage where the hepatocellular carcinoma is confined to one place, let's say the Milan criteria, this is not for you, is PG, but you can do in the early stage, you can do liver transplant also. But later, where you cannot do that, you can do radiofrequency ablation, you can do trans artery chemoembolization. You use chemotherapy through the artery that supplies the liver, you deliver chemotherapy there. And you can also use other drugs like sorafenib. Sorafenib. I think I'll just test it for you people. My pronunciation wasn't that good. Okay. Nib. Hepatocellular carcinoma. So hepatocellular carcinoma you treat depending on the stage. In the early stage, you can do resection, radio frequency ablation, you have to do chemoembolization, and sometimes you have to do this drug. Tried my best to give you guys idea on how to do it. So any question? If no question, then I continue. Any question? Anas, Toro, Aishat, Saibi, or just write proceed if no question. We are going to one of the no question, okay? Maya wrote no question. Okay, so they ask you this question. I'm surprised that I'm seeing similar question in my question bank. And I expected that all of you should have gotten it. So listen very well. You even remember a 42-year-old dentist is reviewed in the medical clinic complaining of persistent lethargy. The routine blood test showed anti-hepatitis A antibody negative, hepatitis B surface antigen negative, anti-hepatitis B antibody positive, anti-core anti-hepatitis B co-antigen, anti-hepatitis B co-antigen negative, anti-hepatitis C virus antibody positive. Let me repeat the combo test. Okay, so they said anti-hepatitis A antibody is negative, hepatitis B surface antigen is negative, anti-hepatitis B surface antigen is positive. The anti for the hepatitis B. The anti-core hepatitis B core antigen is negative. The anti-hepatitis C antigen is positive. So what does it demonstrate? Hepatitis B infection, hepatitis C infection, previous vaccination to hepatitis B and C, hepatitis C infection with previous hepatitis B vaccination, and E, hepatitis B and C infection. So what is your answer? I think they asked you that question. So today we are going to iron out this thing once and for all. This combo interpretation. So what is your answer? Okay, yeah, Sumaya is right. So, okay, Toro is asking which one is positive. The positive are anti-hepatitis B and anti-hepatitis C. So Sumaya is right. Is the answer should be hepatitis C infection with previous hepatitis B infection. So listen, in combo tests, for hepatitis B infection, there are certain things that are there. One of the things that you see there is the hepatitis B infection. Sorry, hepatitis B surface antigen, which usually indicates current infection or a carrier, right? Then you have uh, the E antigen, hepatitis B E antigen, which indicate infectivity or replication of the virus, right? Then you have anti-hepatitis B core antigen, which could be IgM or IgG. IgM indicates uh, acute infection. IgG indicates chronic infection. Then basically that's for hepatitis B. So I'm going to give you certain scenarios that you people should answer. If you're ready, say ready, 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 so that we will answer all the possible combo questions that they can ask you. I think this is one of the hepatitis question that they asked you. But let's iron out combo results. Then we can. Okay, so Isa wrote ready. Good, good, good. So if you have, right, the hepatitis B surface antigen positive, hepatitis B E antigen positive, the anti-hepatitis B surface antigen negative, hepatitis B co-antigen IgM positive, what is your diagnosis? So I'll repeat, if you have hepatitis B surface antigen positive, hepatitis B E antigen positive, anti-hepatitis B surface antigen negative, hepatitis B co-antigen IgM positive, what do you have? Okay, so that we'll sort this thing out once and for all. I'm waiting for my answer, please. Very good. So Isa Yusuf got it, right? Acute viral hepatitis B infection. Good. All right, very good. Sumaya also. The other people, hope you're following. No, I don't want to carry one person. I don't want to carry only one person in this kind of discussion. Did everybody got it? I'm moving to the next possible scenario. There are only two people that answered this my question. Hope you understand the answer. Did everybody understand? Hope I have charge today. Okay, today I have battery, so we will have time to we have time to discuss. We have time to discuss. Okay, so okay, Toro, you said no, sir. What didn't you understand? The issue here is that the surface antigen is positive, indicating either acute infection or carrier state, right? Or even sometimes chronic infection. Okay, the E antigen is positive, indicating active replication, which is suggestive of acute infection, right? The antibody to surface antigen is negative, so that means the individual has not developed immunity, right? And the core antigen is IgM. IgM suggests acute infection. Hope you understand now. Abdullahi. Okay, Abdullahi is you I'm waiting for. Do you understand? All right. So I don't want. Okay, that's good. That's good. So next scenario. Okay, I will just be telling you the positives, right? So that we will not be doing tautology. If the anti-core IgG is positive, right, and the a- anti-surface antigen is positive, and the surface antigen is positive, what does the individual have? Okay, did you get me? The hepatitis B surface antigen is positive. The anti co-antigen is positive, and the anti-hepatitis B surface antigen is also positive. What do you think is the issue? Anti-co-antigen positive, anti-co-antigen positive, anti-surface antigen positive, but still the surface antigen is still positive. What do you think? Any idea? Okay. So chronic hepatitis B infection. Very good. Very good. So especially if the anticore is IgG, isn't it? Very good. So, but what if the uh very good, all of you, very good. Uh-huh. Very good. But what if the anti surface antigen is negative? So what if you have the core positive and the surface antigen positive? Only these two, core positive, surface antigen positive. What do you think you have? The core positive, the surface antigen positive. What do you have? So if you have core positive and the other things are, if you have core positive and the other things are negative, the likely thing you have is a carrier state. Carrier state. Please write it. Carrier state, you have the core positive, the surface antigen positive. So it's a carrier state, and people that have carrier state are less likely to transfer the infection. Are you with me? Please, if you're with me, indicate. So the carrier state is the core positive and the surface antigen positive. If you're with me, please write we are with you, sir. With you, sir. That's the only way I know that you. Good, 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 good. Then the next thing is, how do you differentiate previous infection from previous immunization? Previous infection and previous immunization. Is it not funny? Previous infection and previous immunization. What is the major difference? Does anybody know? Because all of them, previous infection is passive immunization, while previous vaccination is active immunization. So, how do you differentiate the two? So far, I'm impressed with your answers. So, you are getting it right. So, please don't miss these cheap questions. Please, if it comes up, please don't miss it. So, how do you differentiate previous infection that has totally recovered? People can recover from hepatitis B infection and previous immunization. Any ideas? Okay, so let me answer it. So if you see that the individual has positive anti-surface anti-hepatitis B surface antigen, that is previous immunization. But if you see that the person what he has is anticore positive, only anticore positive, right? Okay, so previous immunization, as I said, is anti-hepatitis B that is positive. But if somebody has had the infection and has recovered, right, totally recovered, the hepatitis B surface antigen is negative, what will still remain is the anticore. So that's the major difference between uh, previous immunization from somebody that has had infection, right, is now negative, it doesn't have problem, and somebody, if it is immunization, is anti-hepatitis B surface antigen positive. But there are scenarios in which people with previous infection also have both the anti hepatitis B surface antigen positive and the anticore together, right? But if it is previous infection, there must be the anticore must be positive. But if it's immunization, there is no room for anti-hepatitis B core antigen to be positive if it is immunization. Please take note of this. Okay? So let's see any other topic in, in gastro. We have talked about H. pylori. You said they didn't teach you primary biliary cholangitis, but did they teach you irritable uh, inflammatory bowel diseases? Did they teach you inflammatory bowel diseases? Please indicate so that we sort that out. Inflammatory bowel diseases. Okay, okay, very well, very well, very well. So I'm going to ask you a particular question. There are certain characteristics of ulcerative colitis and some characteristics of Crohn's disease. So if I mention something, you tell me, is it Crohn's or ulcerative colitis? If you have inflammation limited to the mucosa and submucosa, is it UC or Crohn's disease? Please write the answer. Inflammation limited to the mucosa and submucosa, is it UC or Crohn's? I will be giving you people. Okay, so Gani say UC. Any other person UC? Very good. Okay, 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 okay. Okay, very well, very well. Which of them have pseudo polyps. Which of the type of inflammatory bowel disease have pseudo polyps? Which of them have pseudo polyps? Okay, so pseudo polyps, Toro wrote CD, Shaibu wrote UC. Which of them have pseudo polyps? I want to see more answers. Okay, okay, so please pay attention. When you have widespread ulceration with preservation of the adjacent mucosa, right, with the appearance of polyps, which is called pseudopolyps, is ulcerative colitis. So it is ulcerative colitis. Take note, it is ulcerative colitis. It's UC that has pseudopolyps. Please take note. So then let's go to the next thing. Which of them, pay attention, which of them have edema of the submucosa and submucosa combined with deep fissures, fissured ulcers? The fissured ulcer is also called rose thorn, which leads to cobblestone pattern. Which of them have this cobblestone pattern? Is it UC or CD? Which one has cobblestone pattern? Okay, so it's CD. I agree with you. I agree with you. Okay. So which of them, pay attention again, have crept abscesses? Crept abscesses. Which of them has crept abscesses? Which of them have crept abscesses? Is this CD or UC? Which one has crept abscess? See, you need to get a. I think I will try and get the table that will differentiate it and share it with you people. Okay, so it's actually UC that has crept abscess. Please don't miss this. It's crept abscess is seen in ulcerative colitis. Please be writing this thing down. All the scenario and the dancing, dilly dally, it will not pass all these things. So these are salient points that you need. So next, one has prominent globular cells, while the other one has depleted globular cells. So which one is which? So you can say you see prominent if that's the answer, or CD prominent, or the reverse. Which one has prominent? That's much globular cells with mucin secretion, and which one doesn't have prominent globular cells? So type UC prominent globular cells, or UC depleted globular cells, or CD. So. So these are basic things that you need to know. I need answers, please. Which one has prominent? Or if I give you 1 minute, you don't answer it, I'll answer it myself. Okay, because that's the actual. It's not even the last. So the globular cells are more prominent in Crohn's disease, while in UC the globular cells are not. They are depleted. Please take note of that. So in UC the globular cells are depleted. Then in Crohn's disease you have non-chelating granuloma, while in UC granulomas are not usually present. Okay, hope you got that. Hope you got that. Say yes, sir, so that I'll continue. Hope you got the last points. Okay, good, good, good. Yeah, it's all right. So were you taught irritable bowel syndrome? Were you taught irritable bowel syndrome? I'm just trying to do a form of overview for you people. Okay, so I've said that yes, sir, you were taught irritable bowel syndrome. Good. So let me ask you a question, then we will go ahead. So a patient presents with GI symptoms, and the GI symptoms is consistent with irritable bowel syndrome. Which of the following is seen in irritable bowel syndrome? A. A middle-aged woman. B. Altered stool passage. That is, patient having change in bowel habit. Okay. So A. A middle-aged woman. B. Change in bowel habit. C. Abdominal bloating. C. Abdominal bloating. D. Symptoms relieved on eating. Symptoms relief on eating. Then lastly, passage of mucus. So let me repeat, right? So which of these is characteristics of irritable bowel syndrome? Is it A, middle-aged woman, B, change in bowel habit, C, abdominal bloating, D, symptoms relief by eating, D, passage of mucus? Which one is not? Which one is not? So tell me which one. You know, it's best of five. You choose the odd one. So which one is not characteristics of irritable bowel syndrome? Okay. So okay. Uh additional road D. Additional, you're welcome. I'll be waiting to see you participate. I didn't know you were here, Esther. Okay. Yeah. So the symptoms of irritable bowel syndrome are worsened with eating. So, for you to diagnose irritable bowel syndrome, there are certain things you need to know. One, right? The patient must have abdominal pain that is relieved by defecation. Abdominal pain relieved by defecation. Then, plus change in bowel habit, abdominal bloating, symptoms worsen with eating, and passage of mucus. So the characteristics is that the symptoms is usually up to 6 months, at least 6 months. If it's not up to 6 months, it's not irritable bowel syndrome. Okay, hope you have gotten my explanations. And one of the complications are weight loss, right? Weight loss, rectal bleeding, and other problems. Okay, so let's go to another one. Whenever you people are tired, you say we should call it a day. You know, you gave, we agreed on Wednesday, Thursday, right? So today is Thursday. So we can only do this next week if But for now, let's go on. Okay. Okay, you people were taught Crohn's disease. Okay. All right. I don't know what they asked you in. You were taught chronic pancreatitis now. Please write pancreatitis. Were you taught pancreatitis? There's no way that Oga will not teach, HOD will not teach you chronic pancreatitis. There is no way. Were you taught? Write yes or no. Aha, you people wrote yes, 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 yes. Okay. So let me give you a scenario, then we answer. Okay, only acute. But in your MCQ, I saw chronic pancreatitis. Oh. Hmm. Voila. Okay, let me just give you a scenario, then we answer. Okay, okay, some wrote acute. Okay. Uh, okay, let me summarize chronic for you people. When we come to acute, we'll discuss it. So one thing you should know with chronic is usually a continuation of acute pancreatitis. Though some people that develop acute pancreatitis, it usually gets resolved. And one of the major risk factors for chronic pancreatitis is alcohol consumption. So chronic pancreatitis, they usually come with some kind of excruciating abdominal pain, which usually starts 15 to 30 minutes before, no, 15 to 30 minutes after meal. And they also have uh, passage of fatty stool because of lack of the pancreatic juice that contains pancreatic enzymes. And subsequently, apart from having problem with the exocrine aspect, they have problem with the endocrine, so they tend to develop diabetes. Okay, so the what there are certain tests they do. You understand? And one of the tests they do is the MRCP, the magnetic retrograde cholangiopancreatography. I don't know if they taught you that one, but if they didn't teach you, leave it. Okay. And the management is by giving pancreatic enzyme supplements because the pancreatic enzyme are not functioning, leading to that anytime the patient eats 15 to 30 minutes, have serious abdominal pain. You give analgesics. If the patient is diabetic, you also treat the diabetes. But one thing you should know for acute is that one of the most important tests you do for acute is the amylase, right? And I know they taught you that you do the amylase, or sometimes you can also do the lipase. But we'll get there. We'll discuss the acute. Let me see if we can finish gastro today. Were you taught non-alcoholic liver disease? Liver, fatty liver disease. Were you taught fatty liver disease? Okay, okay. I'm seeing 4 years. Any other yes? Okay, were you taught fatty liver disease? Okay, no, 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 no. Okay, it's all right. Nobody will ask you what you have not been taught. Okay, so we have another question on ulcerative colitis. Um, it talks about the treatment. There's treatment for inducing remission and there's treatment for maintenance. Pay attention. So for inducing remission, that's when you use the aminosalicylates and the steroids. But when you're maintaining, that's when you need the azathioprine and mesalazine. Mesalazine, you can use mesalazine, and also you can use mercaptopurine. So for inducing remission, you use the steroids, use the aminosalicylates, right? But for maintenance, you can use methotrexate is not recommended for ulcerative colitis, but you can use it for Crohn's. But you can still use mesalazine and you can use mercaptopurine. So in treating ulcerative colitis, there is two things: inducing remission. I think I only treated one case of ulcerative colitis since I started working with Bauchi. And what we gave the patient was she came in with acute flare, so we gave her steroids and she did well. So during the symptoms, to induce remission, you use steroids or you use aminosalicylates. Okay. Then for the maintenance, I'm sure the HOD mentioned those things. Okay, okay, okay. Did he talk about gastric cancer? Did he talk about gastric cancer or not? So that we quickly jump it. Did he talk about gastric cancer? Or if not, we quickly jump it. Okay, I had said yes. Is it only Aisha that know of that? Is it only Aisha that know that remember that you guys were taught gastric cancer? Okay, additional also wrote yes. Okay, okay, I still have some battery. Okay, still have some battery. Okay, so listen to this question and answer it, please. Which of the following is a risk factor for gastric cancer except? Which of the following is a risk factor for gastric cancer except? Okay, the reason why I want us to cover the GI thoroughly is because he's the HOD, right? And is majorly the person that sets most of the question. So let's make sure we cover his end. But for subsequent one, we will not cover everything. We'll just go to the areas that you people gave me, like filariasis and other things. We'll just go there. But for this one, since it's the HOD, is better we covered everything. So which of the following is the risk factor for gastric cancer? A. Smoking. B. Blood group O. C. Nitrates in diet. D. Pernicious anemia. E. H. pylori infection. So let me repeat. Which of the following is a risk factor for gastric cancer? A. Smoking. B. Blood group O. C. Nitrates in diet. D. Pernicious anemia. E. H. pylori infection. So which one is not? So please answer or that we can move. Okay, so here I have, okay, additional road B. Okay, So Abdurrahman also wrote blood group O. Okay. Any other person? Any contrary opinion? I have only two answers here. I want to see other people answer. Okay. Saib is wrote pernicious anemia. Any other nitrates in diet? Okay. So additional and Abdurrahman, they are right, is blood group O. The rest are risk factors for gastric CA. So the risk factors for gastric CA are H. pylori, blood group A is blood group A, not blood group O, right? So in gastric cancer, you see that in GA there is A, in cancer there is A. That's how to remember. So it's blood group A. Then pernicious anemia, smoking, nitrates in diet, and also H. pylori. So it's blood group O that's the answer. Okay, diagnosis is by endoscopy and biopsy. So when you do biopsy, you see if there is cancer there. Hope you're following me. So this is an opportunity for you people to correct some things, right? In case he brings all these topics to you people. Let me see. We have done hepatitis. Okay, this hepatitis. Why taught hepatitis C separately? Why taught hepatitis C separately? Please indicate. Okay, so I saw no, no, no. Okay, so it's hepatitis B that they taught you. It's okay. So, but know that hepatitis C can also cause chronic hepatitis, can cause cirrhosis, can cause hepatocellular carcinoma. Right? Please note that. And the transmission of hepatitis C is through the blood, vertical or indiscriminate share of sharps or sexual intercourse, unprotected sexual intercourse. Just for your knowledge, this we are not taught, we will not dwell on it. Okay, let me see. So, let me give you a mnemonic for causes of acute pancreatitis. You know, uh, and in acute pancreatitis, one of the central symptom is central abdominal pain. Central abdominal pain that is radiating to the back. There's usual vomiting. Sometimes there may be fever, right? But classically, the amylase will be quite elevated. The amylase will be quite elevated. So let me give you a mnemonic for the causes of acute pancreatitis. So it's usually get smashed, to smash something. So get smashed. So the G is gallstone. So gallstone, cholelithiasis can cause it, right? Then the E, we are discussing about the get now. The E is ethanol. The T is trauma. If somebody has trauma, I have it. Then for the smash, the S is steroids. The M is mumps. But you can add another virus there like Coxsackie B. Then the A is autoimmune diseases such as polyarthritis nodosa. The S again is scorpion venom. The H is multiple things, hypertriglyceridemia, hypercalcemia, and the rest. Then the E is ERCP, endoscopic retrograde cholangiopancreatography. Then the D lastly is drugs that can cause it. They include your bendrofluothiazide, your furosemide, your sodium valproate, your pentamidine. So this is the pneumonia. If you go online, search it, you see it in detail. Get smashed. So what is characteristics of acute pancreatitis? Central abdominal pain, radiating to the back, vomiting, sometimes fever, elevated amylase. If you see something like that, it's definitely uh, acute pancreatitis. Hope you get it. So that we keep going. Ooh. We're dwelling on this gastro because it's, as I said earlier, it is HO this area. So we need to dwell a little bit on it, then forget about it and move forward. I'm looking for a, a scenario. We can just go ahead. Just give me a minute. Let me see anything pertaining cholecystitis. Okay, I've already talked about guest mash. So I don't know. Can you remember any of the questions they asked you on chronic, on acute hepatitis? One of the things you should know about acute pancreatitis is that CRP, C-reactive protein, is used as a marker of severity of acute pancreatitis. We know that amylase or lipase can be done to make diagnosis, but CRP is used to as a marker of the severity of acute pancreatitis. Okay, okay, okay. I'm looking for. I saw a scenario on this thing. Let me check. Please bear with me. Is it that it has disappeared? The reason you people know the reason why I like scenario. I like scenario because it helps you remember. Because if it is just reading, you people can read very well. But if you discuss a scenario, whether you get it wrong or right now, it doesn't matter. You won't forget. Let me see something. So, can you remember what they asked you in cholecystitis? Anyone, please? What was the question on cholecystitis? I couldn't see my scenario here. Sorry. Anybody help us? What was the question on cholecystitis? Can someone type? Because if it is, as I said, if it's to read, you people can read now. Okay, okay, calculus and calculus, right? Okay. So the kai. Uh, but when you taught this thing, so when you see them asking you about calculus and acalculus, all they are pointing at is cholecystitis caused by a stone, and those that are not caused by a stone. And one of the things that can give you cholecystitis that is not from a stone, it can be drugs and other things. I'm coming. So, okay, there was a special question on acalculous cholecystitis. Okay, so that question on, as I said, when you see acalculous cholecystitis, is cholecystitis that is not. Let me see, because most of them they get these questions from certain question bank. Let me see if I can locate it. Bear with me a little bit so that I can explain this thing in detail for you guys. Okay. Uh, no, it's not this one. Uh, okay. Okay, I have a question here. Okay, we were asked the main causes of cholecystitis, if it is GB stasis or sepsis. Okay, gallbladder stasis. No, 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 no. It's mainly sepsis actually. So sepsis can cause acalculous cholecystitis. Gallbladder stasis doesn't cause it actually. So and it's commonly seen in ICU patient indeed. So it's commonly seen in ICU patient actually. So acalculous, that means no stone, is usually seen in septic patients who are in ICU. So gaskiya that's the that's the right answer there. Very good. Please be remembering Esther and Aisha. Any other thing about it so that I can easily answer it. As you remember, that's the only way I can also give an input. Okay, let me give you a scenario of that will help you remember. Pay attention, everybody. So a 43-year-old male was in a road traffic accident, right? And suffered a major trauma. He's now in intensive care unit. He has become parexial, that's fever, and appears to be in pain. On examination, he has tender right upper quadrant. The blood vessels, sorry, the blood investigation revealed elevated LFT, and his amylase was elevated. Okay, he has leukocytosis. You see leukocytosis in acute pancreatitis, right? Please note that. The ultrasound scan showed a distended bladder with thickened walls and pericholecystic fluid. although there's no evidence of stone. What is the most likely diagnosis? Is it acute pancreatitis? Is it hepatitis? Is it calculous cholecystitis or a calculous cholecystitis or ascending cholangitis? So this scenario is for a calculus cholecystitis because the patient has had road traffic accident, right? Which likely has developed abdominal injury. He has evidence of infection and also evidence of pancreatitis. But the important thing there is that the scan, there is no stone whatsoever. And another thing you can see, they said they took the patient to intensive care unit. So this is an example of a calculus cholecystitis. So let me read something generally for you. A calculus cholecystitis is often observed in critically ill patients in the ICU. It is thought to be due to bile stasis in patients that are likely to have increased bile viscosity due to fever, dehydration, or fasting. So this your gallbladder stasis. I don't know if it should be gallbladder stasis or bile stasis. If it is bile stasis due to dehydration, right, or fever, then I agree. So it depends on what they wrote there. So the bile stasis is from dehydration and fever. Uh, so the patient usually has typical symptoms like calculus, cholecystitis. The major difference is that if you do an ultrasound scan, no gallstone is likely a calculus. Hope you got it because I usually like giving scenarios. It makes you remember. Okay, if they said girls bladder stasis, I think we should still agree with them, though it should be bile stasis, right, from dehydration and fever. You know, if they say gallbladder stasis, it could be like a tonic or thickened gallbladder. So you can still go with them. If that's what they wrote, you can still go with them. Okay. Any other thing that was asked about in gastro that we haven't covered, please let me know. Any other thing in gastro that hasn't been covered? And you remember, please, that what is it? Okay, you said they didn't teach you primary sclerosing cholangitis. Okay, okay, the extrahepatic manifestation of chronic hepatitis. So what did they ask about it? Because you know it can cause. Okay, I think I asked someone even during the exam. It can cause glomerular disease. It can cause arthritis, right? So what did they ask during the during the exam? What were the options? This is MCQ. Saebi, what were the options? It can cause diabetes, endocrine. Okay, it was part of the AC. Okay. If it was part of the AC, so was it list or was it to list or to discuss? Was it list or discuss? Okay, if it was list, that means it was okay now. Saibi, it was okay. So what you would do, right, is your good student will always classify, right? So you classify them. Hmm? You can classify them into endocrine. Endocrine, please listen attentively. You can classify them into the system affected. So, like endocrine, it can cause diabetes, hypothyroidism. Like renal, it can cause IgA nephropathy, and it can cause membranoproliferative glomerulonephritis. Okay, so you classify them, right? So I've mentioned two. Then you can also mention hematological. It can also cause non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma. Hope you're with me. Then it can also affect the skin, like lichen planus, like psoriasis, and it can also cause purpura in the skin. Okay, so these are some of the things. Then musculoskeletal, it can cause polyarthritis. So if you look at it this way, you'll be able to remember some things, right? Endocrine hypothyroidism, diabetes. It can cause musculoskeletal polyarthritis, the kidney, IgA nephropathy, membranoproliferative glomerulonephritis. It can affect the skin, lichen planus, purpura, and psoriasis, right? So if you remember it this way, you'll be able to list enough. Okay? Hope you got me. Any other? Let's make sure we are canceling gastro today so that we'll go to next week or anytime you have. Me, I'm on leave. I have all the time. You are the ones fighting against time. Okay. Okay. So, any other question on gastro? Any other question on gastro? Hope you saw areas that you should have passed and you didn't pass. So that, as I said, the examiners don't have any time to say any new question. It's out of the old question that you will be maneuvered from the mock and the final exam. So that's why I'm taking my time to do that. Nobody is going to ask us to set new question. Even if they ask me, I don't have that power. And I've discussed the endocrine questions with you. Any question on gastro? But if you're satisfied, said right, done and dusted. If you're satisfied with gastro, right, done and dusted, so that if you're asked how do you investigate viral hepatitis, will you write an essay? Was it in short note or major note? Adetola, I'm waiting for you. Was it in short note or major note? Okay, so if it's short note, viral hepatitis. So if it is acute viral hepatitis, investigating acute viral hepatitis is uh, one of the things you do is viral screening, right? So you do hepatitis B surface antigen. You know you screen for with hepatitis B surface antigen. You do hepatitis C. Where available, you can also, if you're suspicious of it, you can do anti-hepatitis A viral antibody, right? So that's the screening test. Then you of doing it, okay? Because when you're dealing with acute viral hepatitis, you don't go ahead and be doing viral load, because almost 90% of people that had developed viral hepatitis would seroconvert, they will become normal. So no need to be giving the antiviral at that time. So that's how you investigate. LFT, viral screening, you mentioned the ones you do, then abdominal ultrasound scan. The abdominal ultrasound scan will confirm that if it is just an acute viral hepatitis or acute on chronic is B, though other causes are hepatitis C, hepatitis A, and hepatitis E. Right, since it's short news, then you make sure the investigation. You do the virus screening for all those viruses. You do LFT, which will show elevated. You have to mention short note now. The LFT will show elevated liver function, liver enzymes. However, the albumin may be normal. You know, it's in chronic hepatitis that the albumin is low. So you say that the albumin will likely be normal, but the ALT, AST may be elevated. All right. Then you talk about the ultrasound scan. The ultrasound scan, if it is acute viral hepatitis, there will not be any indication of chronic liver disease, such as distortion, severe distortion of the liver echo texture, or presence of nodules will not be there if it is acute viral hepatitis, but there will just be a mild distortion of the liver architecture. So if you do that, you're home and dry. Hope you got it, Adetola. Okay. Someone asks complications of acute viral hepatitis. Of course, it can turn to chronic viral hepatitis. It can give you acute liver failure or fulminant hepatic failure. It can give you hepatic encephalopathy, isn't it? It can also, if it is severe, it can give you hypoglycemia. If it is severe, like people that have already developed acute hepatic failure or fulminant hepatic failure. So hepatic encephalopathy, progression to chronic hepatitis, liver failure. They can also, though it's rare, that one you see it more on chronic. You can also have, in severe cases, coagulopathy. You know that the liver is responsible for the production of vitamin K dependent clotting profiles. So, but the common complication is hepatic encephalopathy, progression to chronic hepatitis, hypoglycemia. Then in rare cases, you can have hepatic failure, you can have coagulopathy, you can have other problems. Okay. So, Adetola and Aisha, are you okay? Are you satisfied? Any other question? I want to close the chapter of gastro. I want us to finalize on gastro before I leave you people. Any other question? All right. Okay. Gani said done and dusted. Good. All right. So that we can. Okay. Any other? If no question, write down and dusted. Then next week we'll concentrate on infectious. Please, Gani, Abdullahi, Aisha, please give more ideas on the challenges you people had on infectious disease, because that's what we'll start next week. But if you have any time within the week, please inform me early. Inform me early. Don't inform me that very day. If you have any free time, inform me early so that I can also plan for it. Okay, so but next we will do infectious, because based on the things that you people listed is infectious and gastro, that you had most of the problem, right? So please, all these things that we have taught, this is just a building block. You go and read around them, right? I will leave the live program on my channel so that if you want to listen to it again and make certain clarifications there, you can go ahead. Okay, so have a good night rest. My contact is with Adetola. If you need to reach me personally, you can do that also. We will meet again next week, Wednesday. But I will start with infectious disease. But anytime you have it, any space you have, please let me know on time. Right? So good night, everybody. Good night. Good night, Abdurrahman, Suleiman, Anas, Aishat, Anas, Adetola, Adeshina, Abdullahi Toro, Saebi. Okay. Good night, everybody. Okay. We'll continue doing our best for you. And I believe, I have no doubt that all of you are going to pass. We will make sure that we do our best for you, right? So, good night, everybody. Take care of yourself. Bye bye.